Good morning, good morning. Good morning to everyone. How are you all? Came from the Jaipur very late, very tired. Good morning, good morning. How are you all? Good morning, good morning. Please join in. सब बढ़िया, all good. तनुज, या, आशीष कुमार, कृष्णा, या क्या बात है. चलो, we are starting. Good morning, good morning. Yeah. So let's start. I hope you all are doing well. How are your studies going on? So today we'll be doing the remaining part of the medicine, okay, and we'll be trying to finish everything up, okay, and we'll have the question discussion afterwards. Hematology is already taken by Dr. Pooja. I'll take a review and the revision of hematology later. So I'll be doing this later. Right now my target is to finish the other parts of. Good morning, by good morning, everyone. So how are you all? Good morning. So I'm always giving you my blessings. Don't worry. Okay. So everything is good. Everything is very, 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 perfect. And I hope everything is going to, be good always and always. Okay. So the main target here is we are going to, learn the remaining part and it should be perfect to all of you. Okay. Okay. So last class I discussed about the various ECG. Let's revise with them. Okay, if you can tell me, can you tell me what is this is? Tell me. Anyone, what is this thing is? Yeah, already I have. Actually, just message on NLC number. They will help you. Okay. Cardiology I have already started. Cardiology I have already. क्या बात है आयन भाटी? Yes. So it was a very great class, Jaipur. Okay, we learned a lot and fun also. Yeah, it is A systole. A systole. Okay, A systole. So NLC query number is 777003686. This is NLC query number. You can message it. Okay, clear? Fine. So this is A systole. Okay, A systole. Okay, and what is the treatment? Yes, Vijay Purnima, you are right. What is the treatment of A systole? क्या करेंगे? क्या देंगे ट्रीटमेंट बताओ? So what will be treatment? Thank you, Ayan bhai. ठीक है, don't take stress. Okay, if you take stress, what will happen? It will not happen. Okay, better just give your best and study everything good will happen. Yes, CPR with adrenaline. Okay, what is this? Yeah, what is this? Very good. क्या बात है? Someone लो लवली साहू, डॉक्टर आर्टिस्ट प्रज्ञा, ट्विंकल अवधेश, जोयल, शक्तिवेल, ट्विंकल, क्या बात है, वेरी गुड। मार्गरेट, सुल्ताना, पूर्णिमा, शहबाज, दीपक, या यस इट्स बी फिल्म। परफेक्ट परफेक्ट। ट्रीटमेंट इज yes we'll do defib. Vfib treatment is defib. Very good. Yes, very good. Perfect perfect. Then what is this one? This one, क्या बात है? पर परमिशवसम शिवम, ओके ओके, परम शिवम, परम शिवम, राइट, perfect answer. Yes. Yes, Twinkle, Sultana, Arefa, all are right. Anurag, yes. Nayana, Mad Psycho, Someone, Priyanka, Sanjay, Apritam, Arishat, Pragya, Navi, Artist, very good. Yes, it is our sawtooth. It is atrial flutter. Very good. Treatment ABCD. ABCD is the treatment. Perfect. Okay. I'm just revising it. I covered it. I'm just revising it. Okay. Okay. Then tell me what is this one? This one. What is this one? Very good. It is SVT. Yes. Ayan Bhati, Arishat. Yes. Avdesh, Tanuj, Payal. क्या बात है? You all are going to rock. Purnima, Shabas, Shaktivel, Tanuj. Yes. Yeah, Shabaz, you're right. Warfarin also will give in flutter. Very good. क्या होता है? शेफाली, अरेफा, ट्विंकल, दिग्विजय, मार्गरेट, हैबा, याहिया, क्या बात है? पायल, you all are going to rock. Okay. So all those who are watching me, you all are going to pass. Okay. So all would pass. All would pass. So all would pass. ठीक है? Very good. I'm proud of you. You are giving the right answer. Yes. Now what is the treatment? Yes, all will pass. Okay. Treatment adenosine. Very good. So treatment is adenosine. D is for digoxin. Okay. Arishat, if it was not there in the exam, no ECG, doesn't mean it will not come this year. Okay, clear? So this kind of thinking is not a right thinking. This was not in the last exam, so will not come. We study topic because they're important. Okay, and they have a history of ask in the exam. Okay. Chalo. Now I will see the remaining part of the medicine, and that time we're doing the heart failure one. So I'll do from that only. That is the heart failure topics. Okay. चलो let's continue. So we were doing hypertension, we have done. Okay, so last class we discussed till hypertension. So today let's continue the remaining part, heart failure. So heart failure could be cardiogenic, or yes, it causes, if heart fail to pump, it causes cardiogenic shock and congestion. Pulmonary congestion, that the lungs will fill with fluid in left heart failure, and right heart failure causes systemic congestion. Why? Because the right ventricle pump blood to the lungs from the body. So now the lungs will not get the blood, and the blood will accumulate where? It will accumulate in the body. And other features of shock are, there is decreased stroke volume, decreased cardiac output, decreased BP, okay, and increased heart rate due to increased sympathetic. But if there is normal BP, it's called as compensated heart failure. If low BP, it is, yes, decompensated heart failure. Okay, I'll do murmur later, don't worry. Okay, so please check quality at your end. YouTube do a dynamic, setting. If you go and check your link, and in the setting increase it. Okay, increase it. Okay, see Ronak Patel, increase the quality. Okay, it will automatically improve. Okay, it is YouTube quality, not me. Okay, let's continue. Okay, so next question, there are two type of heart failure, systolic and diastolic. Just remember, if heart is unable to pump, that is called as systolic heart failure, poor pumping. Why? Like myocardial infarction, if the heart tissue is dead, it can't do good pumping. Myocarditis, inflammation or fibrillation or any kind of arrhythmia, so these conditions affect the pumping by the heart. So obviously I have already posted the PDF in the Telegram group, Ambika. You can just check it from Integrated Learning Telegram group. Okay, so there will be a decreased stroke volume and also decrease in what? Ejection fraction. Okay, less than 40-45%. So less than how much? 40-45. Okay, so that's why that's the main hallmark, decrease. So blood will not go out of the heart, so increased blood is left in the heart, causing cardiomegaly. Then there is a S3 sound, which is a filling sound called as gallop rhythm. So S3 gallop is an indicator of heart failure. Okay, treatment is we give inotropes, example digoxin. What does digoxin do? Increase calcium. So digoxin will increase calcium and contraction. So digoxin increase calcium and contractility is this. Okay, your video is still remaining there, don't worry. Okay, yeah, yes, okay, I'll upload this. Okay, don't worry. Paras is now okay, he will start taking sessions here. Okay, okay, we'll discuss it later, don't worry. Okay, see, next has been postponed, so don't have to worry at all. Okay, you can ignore the the sessions. Okay, because the minister himself told it will not be applicable to 2019 batch. So that means they will apply 2020. If they apply 20, that means the exam will occur in 24 December. So that means almost postponed for 1.5 years. So that means I think you people should relax and chill, okay, and study. I think I was the only teacher, only person who was telling the chances of conducting next this year are almost zero. Okay, and there was some saying इस साल तो आ गया जी, नेक्स्ट आएगा जी, नेक्स्ट होकर आएगा, नेक्स्ट ही कर लो और मैं नहीं भाई, देयर इज ऑलवेज समथिंग कॉल्ड एज लॉजिक. ओके, एंड समथिंग कॉल्ड एज नहीं, हम तो कराएंगे. सो लॉजिकली इट वाज नॉट पॉसिबल. यस, हाँ, ऑल टीचर वर जस्ट शाउटिंग, ऑल टीचर्स, ऑल इंस्टीट्यूट, नेक्स्ट आ गया जी, नेक्स्ट हाँ, नेक्स्ट जी, नेक्स्ट कर लो, नेक्स्ट की कोचिंग, नेक्स्ट ओके. I was the only one saying no, next you study FMG exam, NEET PG exam. Okay, I said this in my session. चलो, हाँ वही तो करो, नेक्स्ट के लिए क्लासेस, नेक्स्ट का बैच बनाएंगे, नेक्स्ट बैचेस लॉन्च कर दिए, नेक्स्ट के बैचेस ऑल हैव लॉन्च नेक्स्ट बैचेस. ओके, कर लो अब नेक्स्ट बैचेस, करो, पढ़ाओ नेक्स्ट के लिए. चलो, ओके, कोई नहीं, मेरी वॉइस ठीक हो जाएगी। चलो, बिल्कुल भाई, आफ्टर पासिंग डू सपोर्ट अस। Point is, na, you should always say कि there are chances might not, but they openly come and say. I was watching one faculty interview saying अब तो next है जी, आ गया, it is confirmed 2023 no FMG exam. I can put that clip. No FMG exam in December, only next will come. Next is the only exam. Prepare for next. We are next ready. We are making next. So again, चल. Next question. What is diastolic heart failure? In diastolic heart failure, yes, ठीक है, it's not yet clear कि for NEET PG what they will do. Okay, that's what I'm saying. Okay, चलो, so don't worry, everything will be good. Okay, चलो, let's continue. भाई नेक्स्ट अगर आ भी गया तो इट विल कंटेन ऑल 19 सब्जेक्ट, तो उसे फालतू सोचना बंद कर दो, ठीक है, और जो पढ़ेगा वो पास होगा, ठीक है। अगर आपको फिजियो नहीं आती, आपको पता ही नहीं डायस्टोल सिस्टोल क्या है, तो ये डायस्टोलिक हार्ट फेलियर कैसे पढ़ाओगे? आपको ईडी भी नहीं पता, इजेक्शन फ्रैक्शन, इसलिए कह रहा हूँ पॉसिबल नहीं है। यू कैन नॉट स्टडी मेडिसिन वरा विदाउट फिजियोपैथो फार्मा, so they cannot remove physiopatho-pharma. Okay, in fact medicine itself relies on that. Okay, chalo, next question. Okay, so if filling is less, like cardiac tamponade or CP, restrictive cardiomyopathy, EDV will decrease but there will be a normal ejection fraction. ठीक है, इसे बोलते हैं preserved ejection fraction, कितना? 50% or above. Now cardiac tamponade I'll discuss later, so I will not discuss it here, I'll discuss it later. Then S4 sound is there. What sound is there? S4 sound is there. Treatment is correct the filling and beta blocker, which decrease the heart rate and increase the filling. Okay, so systolic heart failure, what is the treatment? Yes, in systolic heart failure inotropes, and in diastolic we correct the filling like pericardectomy or removal of excess fluid from the pericardium and beta block and the beta block. Okay, now there are two kind of heart failure, right heart and the left heart. Right heart and the left heart. Most common is left heart failure. Most common is left heart failure. Okay, and right heart failure occur due to, yes, left heart failure. That's why most common cause of RHF is actually LHF. So less blood will go to the lung, it causes pulmonary ischemia, plus there is poor exchange, so hypoxia occur, plus there is cyanosis. So remember, hypoxia, cyanosis are features of right heart failure, and blood will not go out of the body into the lung, so blood will accumulate in body, so it causes edema, pedal peripheral edema, which is Pitting type. JVP increase. Why? Because the blood is not going where? The blood is not going anywhere, but it is accumulating where? In the JVP. So JVP will increase. So remember one more finding, increase JVP. Are you clear? Then ascites is there, that is fluid will accumulate in the abdomen. Then hepatosplenomegaly is there. The liver shows the CVC liver, that is nutmeg liver. Liver will look like a supari. Have you seen supari, nutmeg? So it look like supari. And also hepatojugular reflux. When you press the liver, the JVP increase. That is called as hepatojugular reflux. Hepatojugular reflux. Okay. Diagnosis. We will have which test? Fluid thrill test. So what test is there? Fluid thrill test is there for ascites. Okay. Here we are doing the fluid thrill. We put the hand in the middle. From other hand, if you tap one side, like this water bottle, if I tap from one side, I can feel the vibration other side. This is called as your shifting dullness and fluid thrill test. In shift dullness, you will tilt the patient. Like as the patient tilts this side, fluid will go that side, the dependent part, and you will do the percussion. So that's why you can check the fluid is shifting from right to left. That is called shifting dullness. And this is what the diagram shows is, yes, fluid thrill. Fluid thrill. It is the PYQ of 2020 exam. Okay. Then come our left heart failure. Left heart failure, there would be pulmonary edema. So what is there? Pulmonary edema is there. Plus in X-ray, there is which appearance? Yes, it is your bat-wing appearance. And curly B line, please remember them. They all could be asked in the exams. Let me show you. Okay, so let's see. This is your pulmonary edema or the pedal edema. Clear? So this is the pedal edema. Can you see the pit form? Okay. Then this is your nutmeg liver. Can you see that? So this is supari. If you people know, okay. So just like supari, there is red color dots and the white, septas are seen. This is your shifting dullness. So when the patient change the position, the fluid will shift that side and that cause dullness. Okay. Yes. This is the bat wing, very famous. Remember COVID-19 bat wing. So this is the white areas are edema. Okay. And this is what it look like a bat. So called as bat wing appearance. Are you clear? Sure. Let's continue. Okay. Now next question. What are the other things? Cardiogenic shock is there. So less urine will be there. Oliguria. Skin become cold because less blood supply to the skin. Vasoconstriction is there. Fatigue is there. Okay. Pitting edema is seen in which condition? In right heart failure. Right heart failure. Okay. See right heart. Okay. Then there is PND. Paroxysmal nocturnal dyspnea. PND. What is PND? Patient wake up suddenly and is very breathless. So that is wake from the sleep with breathlessness. Okay. And also there is breathlessness on lying down. What is that called as? That is called as your, yes, orthopnea. So breathlessness on lying down is called as orthopnea. It is called as a orthopnea. Okay, clear? ठीक है? ठीक है? Right, we need at least 15 seconds. Okay, done. Okay, next, as there is fluid fill in the heart, there is also S3 gallop rhythm. So S3 gallop rhythm. Then dyspnea on exertion. What is also there? Dyspnea. So when you do any activity, he will have the dyspnea. So there would be dyspnea. Then basal crepitation, crackle, rales are in the lung. So there are the sounds in lung because of fluid. Okay. So they all are caused due to this fluid. Next question. Chalo. And also the RBC, will be there. So that cause pink frothy. So it's a very bubbly sputum. So remember, they both are due to fluid in the lung. So they all are because of fluid in the lung. So as the air and fluid become frothy, means bubbly. So bubbly sputum, jhag wala sputum. So bubbly sputum, jhag wala, bubbly. Okay. Now investigation, we do echocardiography, then we check the level of BNP. BNP is brain natriuretic peptide plus galactin. Okay, X-ray, Muga scan. We can do X-ray, Muga scan is best for ventricular efficiency. So what are the scan is? Muga scan is there. So which scan is there? Muga scan is there. Muga. Fine. So what scan is there? Muga scan is there. Are you clear? So if person heart fail, he will die. And if someone die, he is now in the frame. So that's why the criteria is called as Framingham criteria. तो कैसे याद करेंगे? If heart fail, congestive heart failure is LHF plus RHF. Both side failure is there. So person will die. And if he die, we will put a photo of the person. So that's why it is, remember, called as your what? Framingham criteria. तो how to remember? फ्रेम के अंदर हम कब आ जाते हैं जी? सो हम कब आ जाएंगे? जब हमारा हार्ट फेल हो जाएगा. तो फ्रेमिंगम, फ्रेम में हम. ओके. मुगा इज मल्टीपल गेटेड एक्विजिशन स्कैन. ओके. सो मल्टीपल गेटेड एक्विजिशन स्कैन इज मुगा. ओके, डन. तो फ्रेमिंगम मतलब हम फ्रेम में कब आ गए? जब हार्ट फेल हो गया. ओके. So this is the Framingham criteria. Okay, major criteria याद कर लो. Major is basically acute pulmonary edema, cardiomegaly, then two jugular vein phenomena. One is hepatojugular reflex and neck vein distension. Neck vein. Then there is PND orthopnea. That is the sounds we are having. Plus there is also rails. That is the sound I told you. And S3. So दो sounds हैं, दो dyspneas हैं, दो JVP हैं. देखो ये दोनों sounds हैं, ये दोनों डिस्नियाज हैं, ये दोनों जेवीपी हैं, और ये आपका हार्ट बड़ा हो गया, अडीमा हो गया, हार्ट और लंग. तो याद कर लो, हार्ट, लंग, जेवीपी, डिस्नियाज एंड साउंड्स. इससे आपका पूरा बन जाता है फ्लेमिंग. ठीक है. या माइनर इज एंकल एडिमा, डिस्निया ऑन एक्सर्शन, हेपेटोमेगली, नॉक्टर्नल कफ, एफ्यूजन, टैकिकार्डिया. दीज आर माइनर, बट मेन आर, these are the main ones. Okay, clear? These are sounds. Done? Okay. Now treatment. Treatment of heart failure is basically inotrope. So what we should be using? We should be using inotropic agents. So what is the best treatment possible? It is inotropic agents. Okay, fine. But if there is a shock, we will go for noradrenaline. Okay, so basically digoxin, I told you, is the preferred drug for systolic failure. But if there is shock, we will not be giving digoxin. Why take long time to act? So that's why we'll rather be first starting with noradrenaline or dobutamine. Okay, okay. Yes, the best drug for heart failure are your ACE inhibitors or ARB, that is angiotensin receptor blocker. Why they are the best? For mortality and morbidity decreasement and increased longevity. Basically they prevent the remodeling. How? If you give this drug, they will basically reduce the volume, because they all cause increased sodium loss, and this causes the heart to not overstretch, not be damaged by excessive fluid accumulation. That's why they become the best drugs. Then for pulmonary edema, the drug of choice is loop diuretic. So they are for pulmonary edema. Okay, drug of choice. Okay. Then beta blockers can be used in compensated chronic diastolic heart failure. Once again, beta blocker are used in compensated chronic diastolic heart failure, but contraindicated in acute decompensated systolic heart failure. So which condition? Acute decompensated systolic heart failure. Never use what? Beta blocker. Okay. Next question. What is NYHA heart failure classification? So remember, limitation to physical activity. So limitation to physical activity is one feature. So what is there? Class 1, there is no limitation, no sign symptom on activity. He is almost normal. 2, there is a slight limitation and sign symptom dyspnea occur on activity. Which activity? Ordinary activity. Like he is going to climb stairs, he start getting breathless. Okay, going to park for jogging, start feeling breathless. In 3, there is a marked LPA, marked. Okay, and sign symptom will be at less than ordinary activity. That means even going to, let's say, taking a bath. Okay, during bath also become breathless. Okay, or he is, let's say, making something, let's say he is repairing something or tying the shoes, getting ready, he get breathless while getting ready. So this is called as less than ordinary, less than ordinary. And if sign symptom at rest and severe LPA bedridden, that means is 4 people are needed to carry him. That means very soon he is going to have this Framingham criteria. Are you clear? Done? Yes. So now we will discuss the murmurs, etc. But before that, let me do the what first? I will do what first? The JVP changes first. Okay. So let's do what first? The JVP changes. So let's see JVP changes. So important JVP. Please remember this. Rest you can forget. Okay. So remember, first question, JVP changes. Okay. So what are the important JVP changes? If A wave is absent, this is AFib. If there is giant A, it is TS, tricuspid stenosis. Okay, giant A. Ask in the exam. If there is giant yeah, big V and CV. Big V and CV. That means blood is regurgitating TR. Okay, fine. I will tell it. Okay, don't worry. Okay, ठीक है भाई. Iron. Okay. Then next is, yes, if there is canon A wave, canon is AV dissociation. तो याद करना, A absent is fibrillation, giant A is TS, giant A is TS, big V या giant V is TR. Okay, and if there is canon A wave, it is your AV dissociation. So this is your what dissociation? AV dissociation. AV dissociation. Okay, good morning bhai, good morning Piyush. Okay, so now next is, remember, if there is X and Y prominent, yeah, very good Navi, it's yes, go small sign. This is your CP, and if X is prominent, Y absent, this is CT. 100% एग्जाम क्वेश्चन. ओके, सो एक्स वाई दोनों आए, सीपी है. एक्स आया, वाई नहीं आया, ये सीटी है. ये क्या है आपका? सीटी. तो सीटी में क्या है आपका? एक्स इज देयर, वाई इज नॉट देयर. एक्स इज देयर, वाई इज नॉट. So let me first teach you what is CT and this. Okay, CT is, you all know, cardiac tamponade. Yes, 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 cardiac tamponade. यस, एक्स ने काट दिया, बिल्कुल सही बात है. सो टेम्पोनाड में क्या होता है? ठीक है, फर्स्ट क्वेश्चन, सीटी. देयर इज फ्लूइड और ब्लड इन, यस, इन, यस, पेरिकार्डियम या पेरिकार्डियल कैविटी. बिल्कुल सुल्ताना, यू आर राइट, कैविटी एंड कंप्रेस हार्ट. Especially right ventricle. So if that is the case, what happens? There is, yes, poor filling and poor pumping. Poor filling and poor pumping. Poor filling, poor pumping. And if there is poor filling, what happens? Decrease BP. Shock is there. Yes, shock is there. Then as the ventricle is completely compressed with fluid, the even sounds are not coming clearly. So there is either no or muffled, means unclear heart sound. Muffled heart sounds. So heart sounds are muffled. So muffled heart sounds. Last feature. So apart from muffled heart sound, what is the last feature? Okay, there is also increased JVP. Why? Because the blood is not going to the heart, so it will accumulate in the vein. So JVP and neck vein distension. So these three features are called as backstride. Backstride. So what is backstride? It is decrease in the JVP, muffled heart sound, and increased JVP and neck vein distension. And what JVP show? X is there, Y is not there. X is there, Y is not there. And what is the treatment? Obviously it's an emergency. Treatment is remove the fluid by pericardiocentesis. Yes, and also pulses paradoxus. If you want to write, there is also pulses paradoxus. Okay, PP. Yes. So let me show you 1 second. Okay. So let me show you. So this is what I was saying when I said the word pericardio. Can you see? So this is your heart, this is the right ventricle, right atria. So as they get compressed, the heart cannot fill completely and can't pump also. So that's what causes a severe, yes, decrease in the BP. Yes, Ramesh, you are right. Good mnemonic. Okay. और ये वेंट्रिकल कोलैप्स कर गए इकोकार्डियोग्राफी में. Very good. Then this is what the treatment is. Pericardiocentesis. Okay, remove the fluid. So the mnemonic is yes. CT मतलब कट गया. CT मतलब कट गया आपका. And who cut it? Obviously someone. So CT मतलब कट गया. कट गया. कट गया किसने? एक्स ने. एक्स ने काटा. सो एक्स ने काटा. सो नो वाई. और बताता भी नहीं है, मतलब द एक्स डोंट टेल यू. नो वाइज. ओके, नो वाई. तो वाई इज नॉट देयर. नो वाई. वाई इज एब्सेंट. तो क्या बोलती है? या बोलता है. तो व्हाट योर एक्स से? बस ऐसे, देयर इज नो रीजन, है ना, यू आर अ गुड पर्सन या जो भी है. सो नो रीजंस. ओके, डोंट टेल द थर्ड पर्सन, है ना, बट नो रीजंस. ओके, सो दे गिव नो रीजंस, दे जस्ट लीव यू, है ना. सो दैट्स व्हाई देयर इज नो रीजंस. ओके, फाइन. एंड वी शुड नॉट गो बैक. ठीक है. सो दैट्स व्हाई वी विल गो बैक टू ओल्ड लाइफ. गो बैक टू ओल्ड लाइफ when you were without that person. Backstride. सही है? Clear? Backstride. Then backstride. This person is in shock. He is in shock. He is in shock. ऐसे कैसे हो गया? तो पर्सन इज इन शॉक. देख रहा है शॉक, आंखें कैसे इसकी फटी हुई है. सो ही इज इन शॉक. सो ही इज इन शॉक. देन नो साउंड्स आर कमिंग. यू आर आस्किंग बता भाई क्या हुआ, भरा बैठा है. नो साउंड्स. ओके, नो साउंड्स. ही इज नॉट टेलिंग. एंड ही इज फिल्ड विद पेन, फिल्ड विद प्रॉब्लम. सो देयर इज fluid filled. Okay, so veins distended. So क्या है? भरा पड़ा है. ठीक है. So he is having yes filled with fluid. Okay, clear? Filled. ठीक है. So भरा बैठा है. ठीक है, भरा. एंड ट्रीटमेंट क्या करना है? रिमूव द वाटर. पानी निकाल दो. क्या करना है? एक बार पानी निकालेगा ठीक हो जाएगा. पानी निकालना. क्या करना है? रिमूव द वाटर. पेरिकार्डियो. सही है. एक बार पानी निकलेगा अपने आप शांत. सही है. तो इसीलिए याद करना, अपना काम क्या है डॉक्टरों का? इन पेशेंट्स का पानी निकालना, इनका फ्लूइड ड्रेन करना ताकि ये ठीक हो जाए. ठीक है. सो पेरिकार्डियोसेंटेसिस. ठीक है. चलो, इजी. आई केम फ्रॉम जयपुर आफ्टर होल डे क्लास. ठीक है. न्यू टेक 5 hours. आई रीच 3:30 समथिंग हियर. देन आई हैड टू make some MCQ. चलो, done. Okay, thank you Dr. Power of Shiva. Okay, सही है. So pericardiosynthesis. अब देखते हैं हमारा CP. What is CP? Constrictive pericarditis. So what is CP? Constrictive pericarditis. What is the funda about constrictive? Yes. So first is what happens? There is a very hard pericardium. So poor filling. Yes, it's calcified hard. And what are the findings? Just remember the finding. So findings are basically egg in cup, X-ray में egg in cup, Then there is less pulses paradoxus, but there is basically X and Y both prominent. Then also there is what? Yes, small sign. Yes, yes, yes. What is small sign? Increase JVP on inspiration. And cosmol is seen. It is in CP. CP present, CT absent. तो याद करना कुसुम काटेगी नहीं, कुसुम काटेगी नहीं. So kusum will not cut. Kusum will not cut. Okay, so kusum will not cut. तो कुसुम नहीं काटेगी. तो याद करना कुसुम नहीं काटती, सीटी कट नहीं करती. ठीक है. सो निमोनिक क्या है इसका? कुसुम मॉल गई, कुसुम मॉल गई. कहा? इन कनॉट प्लेस, इन सीपी. सो कुसुम मॉल गई इन सीपी. ओके, इन सीपी with friend, male friend, boyfriend, X और Y. So X और Y. So boy क्या होते हैं? X और Y ना. So boys are X and Y, girls are X and X. Okay, that's what the main thing. Okay, X. Okay, yes. सही है. And yes, they had cup of tea. Okay, cup of tea. बस तो ये हो गया इसका. So X and Y CP, X and Y CP, X and Y CP. एंड ट्रीटमेंट क्या है? यस, रिमूव द हार्ड पेरिकार्डियम. सो क्या करना है? पेरिकार्डियम को निकालना. ठीक है, चलो डन है. चलो बढ़िया. तो रिमेंबर दिस, ऑल शुड रिमेंबर, इट इज गोइंग टू हेल्प यू रिमेंबर इट ऑलवेज. सो कुसुम मॉल गई सीपी में विद बॉयफ्रेंड एक्स और वाई. ठीक है, और ट्रीटमेंट क्या करना है? यस, रिमूव द हार्ड फीलिंग्स. ट्रीटमेंट इज रिमूव हार्ड पेरिकार्डियम. ठीक है ना. तो क्या करना है? बीच में जो भी सख्ती है उसको निकाल दो. ठीक है, बी सॉफ्ट, डोंट बी हार्ड ऑन ईच अदर. या वंस पारस इज बैक टू दिस ही विल टेक द सेशंस, सो वी आर वेटिंग फॉर दैट. ओके, यस. चलो नाउ कम बैक टू मर्मर पार्ट. ओके, सो लेट्स रिवाइज द मर्मर्स. ओके, फर्स्ट क्वेश्चन. ओके, whenever the valves are affected, it causes murmur because the flow is affected, and these are valvular lesion. What are the lesion? Left side we have mitral stenosis, mitral regurgitation, then aortic stenosis, aortic regurgitation, or the right side is TSTR, PSPR, tricuspid and pulmonary stenosis and the regurgitation. Okay. Then come causes. So remember, if there's a newborn baby having valvular lesion, always think of what? Congenital. So if a newborn is having and they are present since birth or immediately after birth, it is called as congenital. Okay, like you are hearing murmurs in VSD, that is, or PDA, they all are your congenital diseases. Okay, if it is old person, most likely is degenerative changes. So old have degeneration and mainly calcification which cause the valvular lesion. Young is mostly infection. India, infection, example rheumatic fever is the most common cause in India. In world, it is autoimmune. So remember, rich country autoimmune, poor country like India. So India is, I don't know what to say. India is poor country. Okay, our per capita income is just $2,500. Okay, and that is very low. Okay, like European countries, their per capita income is 30-40,000. Okay, and 10,000 should be there for at least called middle class economy. So that's why we are technically a low income country. Okay, so we are a low income country. तो क्या बोलूं? poor बोलूं? नहीं बोलूं? poor ही है ना. तो India is poor, that's a fact. Okay? Some Indians will be rich obviously because even at the time of Britishers there used to be rich Indian. In fact, the Nizam, okay, he used to be the richest person. ठीक है, Usman Ali. Okay, he was the richest person in the world in 1930. They used to use big diamonds as paperweights. They were rich, that rich. Okay, chalo. Now the most common valve affected, the mnemonic for valve affected is matpio. matpio, MATP, MTP याद कर लो. So M is mitral valve. Okay, yes, thank you Dr. JD. Keep watching. And AV, TV, PV. So remember MV, AV, TV, PV. So what are the most affected valve? MV, then come AV, then come TV, then come PV. So what are the most affected? Mitral valve. Least affected is the, yes, our pulmonary valve. Who's the largest one? Largest is mitral valve. Okay. Investigation, always we do echo. Okay. Thank you, Dr. Prasanna. Okay. Yes. X-ray, ECG, MRI. X-ray, ECG, MRI. Okay. So mnemonic is मत पियो, मत पियो. क्या मत पियो? दूसरों का खून मत पियो. ठीक है. Don't drink other people blood. मत पियो दारू. Okay. Clear? So not good. Okay. Then treatment. If it's mild asymptomatic, just avoid exertion. No need to give any treatment. Okay. Clear? And if severe or there's a heart failure, low ejection fraction, patient have severe signs symptoms, then we will do surgery. And what you do? Valvuloplasty, or we can do valve replacement. Okay. So what is preferred? Plasty or replacement? What do you prefer? Plasty or replacement? Tell me. What is preferred? Plasty or replacement? Tell me what is your observation. What we should do? Plasty or replacement? Yes, very good. So plasty is repair. Always try to repair first, then do replacement. Okay, like example, if your partner, partner, husband, wife, friends, if they are not good, what we should do? We should repair them or you should replace them. Obviously, we should repair them first. Don't try to replace them. Okay, it's not easy to replace. Okay, like you can't replace your kids. Like if your kid is not good, what do you do? Or parents not good? Oh, this father is not good. I'll get new father. New father? How can you get new father? Matlab, kuch bhi. So that's the case. Okay. Okay, clear. And to replace, you should have options. Na? Clear. Relative you can't replace. Okay, so that is the case. Okay, so you can just ignore the relative. Okay. Okay, now S1 S2 is systole, S2 S1 is diastole. So S1 S2 is systole and S2 S1 is diastole. Remember that? Okay. Hello bhai Deepak. Chalo. So let's start now. This is systole. This is diastole. Okay. Okay. कोई नहीं. रिलेटिव के लिए गाना नहीं है. मैं भी चंगा, मेरा ब्रो भी चंगा. ठीक है, सही है ना. मैं भी चंगा, ब्रो चंगा. बस. ओके, ये हो गया अर्ली. दिस इज मिड, दिस लेट. अगेन अर्ली, मिड और लेट. फाइन, सही है. ओके. नाउ इफ अ मर्मर कम in this part, it is called as early. This early systolic murmur. This will be mid systolic murmur, late, early. So that is what the systolic murmur is. And if the murmur come throughout the cycle, it is called as pan systolic. So if the murmur come like this green one is PSM. What is PSM? Pan systolic murmur. Okay, pan systolic. So pan systolic is PSM. Okay, PSM. Yes. Okay. So remember, first, which subject we always have changes like MR, IMR, MMR, under 5 MR, prenatal MR. So what subject we study and we have MRs? It is PSM. So remember, PSM is always having. क्लियर, एंड प्लस पीएसएम पढ़ पढ़ के लोग मर जाते हैं, सो रिमेंबर यस पीएसएम पढ़ के मर गए, तो रिमेंबर एमआर इज पीएसएम, ओके, mitral regurgitation. So pan-systolic murmur is MR. Pan-systolic is MR. Okay. Then you people should do what? Give NEET PG for MD and MS. Okay. So if you are giving exam either MD or MS. So mitral stenosis we get which murmur? MDM. So MD MS. So mitral stenosis we have mid diastolic murmur. So mid diastolic, okay. So mid diastolic is MS, okay. Then yes, बिल्कुल सही twinkle, very good, okay. Then if there is our AR, it is early diastolic. EDM. So AR is early. AR is early. Yes. So what is AR is early diastolic murmur. Okay. So कैसे याद करेंगे? early AR. Early is AR. Okay. And if there is AS, it is MSN. Mnemonic for this is आस पास देखो. आस पास. ASPS. That is ASPS. And मत शर्माओ. मत शर्माओ. शर्मा से क्या शर्माना? तो मत शर्माओ. MSN. So ASPS what is the murmur? It is आसपास मत शर्माओ. मत शर्माओ. Okay. Okay. Yes. Very good. Ayan Bhati. Yes. क्या बात है? मृगेंद्र कुमार. Yes. Dear murmur. Yes. Good murmur. So it is early. Okay. So are you clear? So these are the four main murmurs. Let me show you. So first is, remember, okay, this is MSM. So if there is a mid systolic murmur, it is AS and PS. ASPS. If mid systolic murmur, ASPS. Okay. And since in AS there is less blood into the aorta, it causes fainting, that is syncope. Heart is not getting blood, ischemia occur, angina, and person also become dyspneic. So dyspnea is also there. So what is also there? Dyspnea. So what is the finding? Syncope, angina, dyspnea in AS. So the finding is AS वाला sad है. AS वाला. So आसपास देखो मत शर्माओ. Why you are sad? दुखी क्यों हो? Sad. So sad. Then if there is MS or TS, this is the mid diastolic murmur. In mid diastolic murmur, there is also called as rumbling murmur because the murmur is decreasing. So called as rumbling. Plus there is the sound called as opening snap. So opening snap plus mid diastolic is MS. It is MS. MR is your pan systolic murmur. MR is which murmur? Pan systolic murmur is MR. It is from S1 to S2, and this is the most common cause is mitral valve prolapse. Which is the most common cause? Mitral valve prolapse. And the clinical features, most likely you will see a young female with acute panic attack, and the murmur increase on standing. So that's why the murmurs increase on standing, because gravity will pull the mitral valve downward, so more regurgitation. So that's why murmur increase on standing. So remember, what is MR? Mitral regurgitation. What is the most common cause? It could be, it is MV prolapse. Okay, and it's very commonly seen in young female with acute panic anxiety attack. AR is early. So that is early diastolic murmur. So it is early diastolic. Sometimes it can be mid diastolic also. If mid diastolic, this is called as Austin print. Austin Fred. And AR is the one with highest number of signs. If you see lots of signs, it is your AR. So what are the signs we will see? Answer is first is there would be collapsing or water hammer pulse. So the pulse as you raise, it just fall down, collapsing pulse. Corrigan, that is dancing carotid. The carotids are moving like a snake, called as dancing carotid. Then there is Quincke sign, that is capillary pulsation at the fingertip. Then there is also Hill sign. The BP is different in upper limb and lower limb, that is called as a Hill sign. Traube or pistol shot over the femoral artery. Mueller sign is uvula pulsation. Lighthouse's forehead becoming red, white, red, white. So these are all seen in the case of AR. So just remember AR is multiple signs. What is multiple signs seen in AR? So summary, MS is MDM. MS is MDM. MS is MDM, mid diastolic murmur. AS is mid systolic murmur. MR is pan systolic murmur. AR is early diastolic murmur. And this is the photo of all the murmur. So early, mid, late. So mid diastolic murmur is seen where? Mid diastolic. I'll make it, you tell me, okay? Let's do it. S1, S2 and S2, S1, okay? So let's start. You tell me which murmur it is, okay? So can you label the murmurs? What is the green one? Green one, green, green. Green is pansystolic. Green is PSM. It is MR. Yes, yes, yes. It is MR. What is the blue one? Blue one, blue one. It is MSM. It is AS. Then the black one. What is black one? It is EDM. It is EDM. Black one is EDM. And EDM is AR. EDM is AR. So EDM is AR. EDM is AR. Then this is MDM. Most likely MS. Can you remember this? Very good. Okay, I'm proud of you. Thank you, Sam bhai. Okay. So I was taking revision class in this Jaipur. Night I will go to Vijayawada for my PG classes, and I am here now offline. I have class after this. So after your session, I will take a offline class. So yes, I'm just making my work. So same thing, you keep making efforts, okay? Don't look at the results. Results will come, but worrying about the results is not good, okay? What will happen? Will I pass? See, you will pass. That's for sure, okay? Only thing is stop thinking about what will happen, how it will happen. Okay? Be positive. Chalo, so done? Okay. Now we'll discuss the very important, that is rheumatic fever, okay? It's a streptococcal infection, okay? Type 2 hypersensitivity because antibodies are formed. Okay? And this protein M is the one which is the antibodies mainly make. This will cross react and damage our joints, heart, etc. So this damage is going to cause what? It is going to cause the, yes, destruction of the flow, etc. Okay. Then there is a criteria we use called the revised zones criteria. So the criteria revised Jones criteria, or the criteria revised Jones criteria. There is two major and one major plus two minor. So there is two major or one major plus two minor is the criteria. So two major or one major plus two minor. Okay. Now what is the major is? Major is Jones. J for joints. Joints show migratory polyarthritis. Then O is for carditis. In carditis, it is most commonly MS, mitral stenosis, and it causes a Carey-Coombs murmur. Mid diastolic murmur. Are you clear? Carey-Coombs mid. Then N is nodules. Which nodules? Subcutaneous nodules. What is N is? Subcutaneous nodules, especially at the extensor surface, hard. Then E is erythema marginatum. So what is E? Erythema. It is just like a love bite. It looks like love. Central area is clear and a red circle is there or outside that. So look something like this. See. So these are your erythema marginatum. Central area is clear. So this is your erythema marginatum. Okay? And Sydenham chorea. So Sydenham chorea is dance. The person will do dance movement. Okay. And what is the treatment? And what do you see? A patho mein we see rheumatic या Ashkoff body. Rheumatic granuloma and fibrinoid necrosis. And eosinophilic collagen. Etc. So many findings are there. Yeah, Ashkoff body, rheumatic granuloma, fibrinoid necrosis. Treatment is penicillin. Benzathine penicillin. Okay. So we'll give benzathine penicillin. So benzathine penicillin. Amit, I have covered that point very well in my physiology class. You can watch it there. How the cardiac cycle phases are seen. Watch the physiology revision class. Okay, just search YouTube physiology revision. It will be found there in that interior learning. Okay. Yeah, he will take chanting soon. Don't worry. So benzathine, how much? 1.2 million units. So we'll give how many units? 1.2 million units should be given in adults and 0.6 in children. Okay. Yes, 1.2 is for adult. Benzathine penicillin, and we give injection IM depot IM injection. Okay. Okay. Okay, I'll update about that soon. Okay, don't worry. Okay, we'll update about that very soon. Okay, चलो. Now let's start. So ये हो गया हमारा PDF खत्म. So now what I am doing is I am saving it and I will post it so you can use it. Now I am doing the remaining part using my own PDF. Okay, so do the nephro now. Okay, and then I'll do the briefly the GIT part and then we'll finish. Okay, hemat is all done by Dr. Pooja. I'll take reviews. Don't ask me, sir, when will you take hemat? So I'll not take the hemat now. So I will be doing that from the file now. Okay, so let me just start and take that and revise. One second. Okay. Okay, just a second. I'll start. One second. Okay. So let's discuss that. Yeah, I will post that PDF. Don't worry. Okay, Mahi. I'm just preparing that. I'll post that very, very soon. Okay. So I'm just opening the file to do the remaining part. Okay. Yeah, take a 2 minutes break. I will continue. Okay. But don't take a longer break because I will start in just a minute. Okay. I'm getting the file downloaded. It's almost done. So it's getting downloaded. Okay. Medicine file. Once done, I will use it for the remaining part. Okay. So that's good. Okay. If you did the medicine, it's very good. I will post the bigger file also. Don't worry. Just a minute. Okay. Done. Point is, I am comfortable only with my own notes. So let's continue with the medicine. We are back. Shabazz, come back. So this is my by Sonakshi Thakur. Okay. So let's discuss our kidney. Then we'll take a break, and after kidney, we will do other things. Okay. So let's start. So in kidney, we have three kind of diseases. What are three kind of diseases? One is pre-renal, that is problem is not in kidney but less blood supply, like shock, heart failure, vasculitis. So kidney is not. In case the problem is in tubule, it is called as a renal disease, like tubular, glomerular, vascular. And if there's an obstruction to the outflow, like calculi, benign prostatic hyperplasia, or some infection, stenosis, tumor, they all are post renal. Okay, they are all called as a post. Okay. Yeah, it's raining in Delhi, Gautam Nagar also. Now next question, if kidney can't function, there would be accumulation of nitrogenous waste. Example, urea, uric acid, creatine, they all accumulate, and this is called as azotemia. So what's azotemia? It is waste accumulation. It's called as azotemia. Okay. Now we'll do KFT. What is KFT? Kidney function test. We check the urea. Urea is 20 to 40 milligram percent. Half of the urea is called as BUN, blood urea nitrogen, roughly half. So 10 to 20 milligram percent. Then we have the serum uric acid, which is 4 to 8, and creatinine is 0.5 to 1. So just remember the important one, that is 10 to 20. So what are 10 to 20? Burn is 10 to 20. You take a burn creatinine ratio, that is burn divided by serum, again 10 to 20. Urine creatinine and serum creatinine, again 10 to 20. And the specific gravity is again 10 to 20. So all these values, if you see, they are 10 to 20 range. So that is something very very, you can say, interesting. Okay, they all are which values? 10 to 20 range values. So it make our work easy. You can remember it. They all are what range? 10 to 20. Again 10 to 20. So 10 to 20. Okay. It's not gram. It is just 10 to 20. Okay, it's not gram, it's just 10.2. The mistakes will always be there, but so let's start. Okay. Now there's a hormone called as ADH. It basically controls the urine output by absorbing the water. So what it do? It control. So ADH cause what function? Water reabsorption via aqua pouring to V2 receptor. So ADH increase what? The water absorption. So urine will decrease. So it make what urine? Low volume, concentrated, hypertonic urine. So that's why it can make the urine hypertonic also, less ADH, and if more ADH, hypertonic. So who decide the urine? ADH will decide the urine osmolarity. Okay. Now normal urine output is 1 to 2 liter per day or 40 to 60 ml per hour. How many ml? Yes, 40 to 60 ml per hour. Okay. Now if there is kidney disease, the urine output can decrease. So if weight wise we take, it become 1 to 2 ml per kg per hour. Okay, 1 to 1.5. So in renal injury and diseases, it become less. So the normal value, it is 1 ml per kg per hour. So just remember 1 kg per 1 ml per kg per hour is the normal value. Okay. And in failure, it become 0.3. So remember, injury 0.5, in failure, it become 0.3. That is oliguria. So what are the value? It become less. So when is the urine output decrease? In kidney damage, failure, etc. Okay. Polyuria is when it's above 300. That is almost double at 2 ml per kg per hour. Okay, 2 ml per kg per hour. Now there are two disorders of ADH. One, either there is less ADH, that is called as diabetes insipidus. Okay, so less ADH is called as neurogenic or central DI. If ADH is normal but fail to act, it is called as nephrogenic DI. What is it called as? It is called as nephrogenic DI. So what is nephrogenic DI? The ADH is there but it failed to act. Okay. Next question. Clinical features: less water absorption. So polyuria, you make lots of urine, you drink lots of water. There is what? Yes. I don't know what this is. I think dehydration. Yes, obviously there's loss of water. Dehydration. Then low osmolarity urine. So urine is having low osmolarity. Okay. So that is less than 500. Less than 500 could be as low as 30 or 50. Specific gravity decrease because this containing less salt and more water. So there is a decrease in urine osmolarity. Plasma osmolarity will increase. So what increases? Plasma osmolarity increases more than 300. More than 300. That is 310, 320, 325. So high plasma osmolarity. Normal is less than 300. Now it's more than 300. Now drug of choice for neurogenic DI. Normal drug of choice is desmopressin. But for nephrogenic DI, it is thiazide. Thiazide cause sodium loss. Then there is a compensatory sodium and water reabsorption, which reduce the polyuria. Okay. Fine. Lithium induced DI, we use amyloride, which is also used in Liddle syndrome. Lilly-loride. Clear? Thank you, Bhavani bhai. See, offline is different. Okay, I prefer offline because in offline there is a different kind of energy and environment, and we are able to learn much better. But again, we are doing online also with same enthusiasm. Only thing is, in offline, yes, it feels very nice to come see each other. Okay. What is SIADH? It is basically syndrome of inappropriate ADH secretion. It's not accumulation, secretion. So mistakes are there, but koi baat. So the syndrome of inappropriate ADH secretion. Okay. So there is the increase in ADH level. There is an increase in the ADH level. Okay. Because of what? Pituitary adenoma or some paraneoplastic syndrome like lung cancers can make the ADH. Okay. Now comes the question: if there is more water absorption, there will be less urine, and the urine will be hypertonic, more than 600 milliosmol per liter, and the urine gravity will also be high because the urine is concentrated. But the problem is what? All the water from the urine is going to the plasma, and this water will dilute the plasma, called as dilutional hyponatremia. So that's why the plasma osmolarity decrease, less than 280 to 75, and sodium level also decrease, not because less sodium but because of more water addition, more water addition. Clear? All will pass by, tension na lo. Everything will be good. Now, low osmolality leads to water entry into cells, especially neurons, okay? And that cause swelling of the neuron, damage to the neuronal myelin sheath called as central pontine myelinolysis. Myelinolysis. Again, so I'll write it again, myelinolysis. So myelinolysis is there, okay? Just do the previous one and write the important one. Clear? ठीक है. Yes, Sidhu Musa bhai, I told it. Okay. Others were shouting on the voice, top of the voice, कि नहीं हो रहा, एफएमजी बंद हो गया, एफएमजी वालों मत चढ़ो एफएमजी इंस्टीट्यूट के चक्कर में, ओनली फोकस ऑन नेक्स्ट, ओनली नेक्स्ट, वी आर ओनली नेक्स्ट रेडी, बाकी नेक्स्ट रेडी नहीं है. मतलब एज इफ दे आर द ओनली वन हु गेट एवरीथिंग फ्रॉम गवर्नमेंट. डायरेक्टली मिनिस्टर आके इनको बोलता है एग्जाम बंद, एफएमजी ओनली नेक्स्ट, यू पीपल स्टार्ट योर स्पेशल नेक्स्ट क्लासेस. अब नहीं हो रहा, क्या करोगे? जो आप नेक्स्ट के लिए बैच बना रहे थे, अब क्या करोगे? तो वही बात है, डोंट बी सो एग्रेसिव in your assumptions just because you are doing some next special thing. Point is, what will happen will happen. This is India. It's a very slow process. It takes long time for things to change. Okay, so it cannot be put immediately because student future is at stake. It cannot be like government ने बोला बना दिया. It's not like that नोटबंदी कि नोट बंद कर दिए. Okay, clear? There was a reason. Corruption, black money. So people agree. But what is the purpose of next exam? So that's why it's not going to be easy to bring and implement. Okay, chalo. So that's what I'm saying, no? Okay, so let's continue. Okay, so what is the treatment? We give hypertonic saline. Okay, okay, so hypertonic. See, don't do any other. We already have posted hematology notes. Okay, so don't worry, I'll post the extra segment. This extra part I will post. Okay, इसी को उसमें मर्ज करके फाइल बना दूंगा. ठीक है. हाइपरटोनिक सलाइन क्या देना है इसे? हाइपरटोनिक टू इंक्रीज सोडियम 3 और 5% सलाइन. ड्रग ऑफ चॉइस इज वैसोप्रेसिन एंटागोनिस्ट कॉल्ड एज वेप्टान. कॉल्ड एज वेप्टान लाइक कोनी वेप्टान, टॉल वेप्टान. ठीक है. मोजा वेप्टान. ओके, ठीक है. GFR. GFR is best given by creatinine clearance. We use the CKD formula. This is the CKD formula for calculation. Do you think you can remember this equation? No, no, then leave it and no need to do it. Just remember DMSA is used for our morphology of kidney. So what give you morphology structure of kidney? DMSA. It is DMSA. And for perfusion blood flow we use DTPA, that is perfusion scan. And MAC3 is when kidney die. जब किडनी मर गई. ओके, मर गई किडनी. मैग इज मर गई किडनी. मैग इज मर गई किडनी. वी यूज MAG. Now next question is acute tubular necrosis. So what is acute tubular necrosis? The most common cause are NSAIDs. So the most common cause NSAIDs plus paracetamol. It inhibit COX and that's why it causes decreased prostaglandin and that result in a net vasoconstriction. Why? Because there are some prostaglandins which cause vasodilation. Remember? So they cause vasodilation. Okay. If they are reduced, it causes ischemia. Okay. And that cause this destruction of the tubular cell. If the destruction, less reabsorption will be there. And if there is less reabsorption, obviously it is going to be a problem. There would be polyuria, loss of water, sodium, etc. So urine sodium increase because you are losing it. It become more than 30 millimole per liter. That is sodium loss. So hyponatremia is there. And there is also increase in the FANA. What is FANA? Fractional excretion of sodium. It become more than 1%. So the treatment, stop the drug, give electrolyte supplement, and the drug of choice is NAS. What is NAS? Is N-acetylcysteine. N-acetylcysteine is NAS. Okay. So once again, what is NAS? Is N-acetylcysteine. Clear? Okay. Now acid base I've discussed already. So I'll just discuss. Okay. So there are two kind of lesion. RTA is renal tubular acidosis. It is the normal plasma anion gap acidosis. So what happens is there is an increased urine anion gap. Okay. So what is normal? Plasma anion gap is normal. That's why RTA causes nagma. Antidote of paracetamol is N-acetylcysteine. Okay. Yes, N-acetylcysteine. Now nagma. Okay. So nagma is normal. So what is nagma is? Nagma is our which condition? It is our normal anion gap acidosis which is taking place. Okay. So that is the main finding in this case. Okay. Yeah, we'll take PYQ soon. Don't worry. Okay. RTA1 is what lesion? Distal tubular lesion. RTA2 is what? Is PCT lesion. So RTA1 is what lesion? It is distal tubule. RTA2 is PCT lesion. Just remember one logic. If distal tubule damage, it's RTA1. If proximal damage, it is RTA2. And other name is distal tubular acidosis and proximal tubular ES. Bilkul Nagma Rad. Very good. So RTA2 is ES. It's PTA, proximal tubular acidosis. Now urine acidification ability is lost or reduced in RTA1. So it's lost or reduced in the RTA1 and normal in RTA2 as distal tubule is still working. Okay. So here urine pH will be yes, non-acidic or less acidic. It should be less, non or less acidic urine. So the pH of the urine become more than 5.5. Just remember the summary, don't remember any of this, and treatment is same. We give bicarbonate and potassium. Bicarbonate, potassium. We also add hydrocortisone in RTA1. So I'll just give the summary, leave everything. So first remember, if you check, if there's hyperkalemia, it is RTA4. So hyperkalemia is RTA4. RTA4 is nothing but Addison disease, which I have told you already. RTA4 is Addison disease. If there is hypokalemia, it's RTA1 and 2. Check the pH. If pH is more than 5.5, urine pH, it's RTA1. Less than 5.5, it is RTA2. Treatment, hydrocortisone plus potassium and bicarb. So clear? So that is your treatment. Okay. So treatment of RTA is what? Potassium, bicarbonate and also hydrocortisone. Next question. This I've discussed already, the azotemias. Okay, less blood flow, etc. Just remember that in all the RTA, what is the main thing? That is the kidney is not getting the blood, is pre-renal. Tubules are damaged, is renal, and post is obstruction. Okay. Now acute renal failure or injury, okay, is less than 3 months. Acute is less than 3 months. We use the rifle criteria. What is rifle? Rifle is asked in the exam. It is risk, injury, failure, loss, and end stage kidney disease. End stage kidney disease is ESKD. Okay, ESKD. Clear? ESKD. So what is ESKD? End stage kidney disease. Okay. Now understand, loss has 4 letters. It is 4 weeks. So 4 weeks of acute renal failure for 4 weeks is called as our loss. And end contain 3 letters, 3 months. So it is 3 months. Khatam, tata, bye bye. So अगर खत्म हो गई इसकी kidney 3 months. So 3 months is our end stage. 3 months is end stage. So for the treatment, we do dialysis or the renal transplant. Okay. Now for RIF, what do you check? We check the GFR, creatinine and urine output. Okay. Now let's revise. R is risk. Risk is 25%, injury 50%, failure 75%. Let's revise it. So I want you people to revise with me. So tell me, what is rifle criteria used for? It is for kidney damage disease. Yeah, they are sufficient. Okay, just do the PYQs also. Okay, Yadu Krishnan, because I am just doing a revision. It's not the main notes. But if you have read the medicine once, just doing them will revise important concepts. Okay, so R is risk, I is injury, F is failure. R is risk, I is injury, F is failure. What is F is? F is failure. So risk, injury, failure. Risk, injury. GFR. So first we'll see GFR. So GFR fall. More than 25%, more than 50%, more than 75%. Okay. And if failure is for 4, it is called as loss. Loss is failure for 4 weeks. And last is our end stage, and is 3 months. Clear? Okay. Very good, Prashna. Very good. Okay. Then come our serum creatinine. Remember, it will double when 50% there. So when you will have 50% value, half to double jayega. 2 times. This is 3 times. This is 1.5 times. Okay. And last is urine output. In ml per kg per minute per hour. Okay, ml. So remember 0.5, 0.5, 0.3. See, best is inulin, but clinically uses creatinine. So you should mark inulin because they're asking best. So 0.3, 0.3, 0.5, 0.5, 0.3. Okay, into how many hours? 6 hours, 12 hours, and 24 hours. So these are the values. That is 6 hours, 12 hours, 24 hours. 6 hours, 12 hours, 24 hours. Done? So please remember this table. It will be there in the exam. One of the most important tables for exam solving. Okay. Okay. So this is the case. So creatinine increase 1.5 time, 2 time, 3 time. Urine output decrease 0.5, then 0.5, then 0.3, 0.5, 0.5, 0.3. 6 hours, 12 hours, 24 hours. Okay. Now features are obviously less urine because of kidney failure, increase urea. So that can cause uremic encephalopathy. So brain is damaged and it causes confusion, memory loss, delirium, tremor, even coma can be there. Okay. Then uremic pericarditis, heart is affected, can cause arrhythmia, palpitations. Then there is white color uremic frost because of urea give white salt like appearance, snow like, sorry. So it causes uremic frost. Okay. So that's why urea is, and also there is a dry itching in the skin. So dry and itching. Okay. Then nausea, vomiting, abdominal pain is there. Hyperkalemia, metabolic acidosis is there because of, yes, too much acid accumulating in the body. Anemia because kidney will not be able to make. This is mainly seen in chronic condition. So less erythropoietin can cause anemia. Then you can find the features of cardiac disease if there's a prerenal cardiac disease. Okay. If renal fluid overload can be there, excessive volume can be there, high pressure edema can be there. Why? Because kidney is not making urine, so fluid is accumulating. Then osteoporosis is due to low calcium and low phosphate. Okay, so that's why there is a low calcium because of, yes, kidney not working. Reproductive organs, you can say system failure like this, low libido, impotence, ovulation failure, amenorrhea, because urea suppresses the pituitary gland. Okay, clear? So urea will suppress pituitary gland. Okay. Next question. One second. Okay. Next question. There's also hyperuricemia, which causes the gout. Okay. And investigation KFT. What is the investigation? KFT. We'll do kidney function test, urine examination. There will be proteinuria, hematuria. So they are the tests. Now, what is the treatment? Always correct the underlying cause. Like example, if shock is there, give the blood, give inotropes, correct. Then correct the electrolytes. Okay, example, salt and fluid restrictions. What to do? Salt and fluid restriction in renal postrenal, so that the edema, the fluid overload can be corrected. Diuretics, so they will increase the urine output and reduce the overload of volume. ACE, ARB are the drug of choice in case of kidney diseases due to especially diabetes. Then recombinant erythropoietin for anemia correction. Metabolic acidosis will correct with bicarbonate, and hyperkalemia will correct with calcium gluconate, insulin, and beta agonist salbutamol. Okay. Now, if there is not corrected, we'll use dialysis. So drugs not working, dialysis. So if drugs are not working, we'll use the dialysis. Okay. Next question. To correct hyperuricemia or gout, we will have drug of choice, that is allopurinol. So what is the drug of choice? Allopurinol. Okay. And what is the mechanism of action? It inhibits the xanthine oxidase. Okay. Correct the calcium, we'll use calcium phosphate supplements, also vitamin D. Scleroderma crisis, drug of choice is ACE inhibitor or ARBs. Then rhabdomyolysis. If there's a rhabdomyolysis, force alkaline dialysis. Okay. Now dialysis is using a membrane, artificial membrane, to remove the waste. That is called as dialysis. And indications are A, E, I, O, U. That is vowels. So all the vowels are the mnemonic vowels. A for acidosis, which is refractory, not responding to treatment. So if you are giving treatment, still patient is not getting the correction of the acidosis, will go for dialysis. Then electrolyte imbalance, that is refractory hyperkalemia. So which hyperkalemia? Refractory hyperkalemia is the funda here. So refractory hyperkalemia. Intoxication. So also one more feature is intoxication is there. In intoxication, barbiturates. There is barbiturates, theophylline, then aspirin, okay, INH, lithium. They all are responsible for this changes. Okay. So they are what? This changes. Okay. Done. Edema. If edema not corrected by drugs also, again we'll go for dialysis. And uremic pericarditis or encephalopathy, again we'll go for dialysis. So what are the 5 indicators? A for acidosis, E for electrolyte like hyperkalemia, I for drug intoxication, O for edema, U for uremia due to urea. So dialysis, we make AV fistula, or sometimes we can use a graft. So we can use a graft also, or we can create. Fistula take months to actually prepare. That's why if acute, we'll use a graft, we can use a graft. If it's a chronic need, we need to give a AV fistula form. What are the new markers of kidney disease? They are KIM1. What is KIM is? Kidney injury molecule. Cystatin D, they ask very commonly. What is cystatin D? Cystatin D is very, very important in kidney diseases. NGAL from neutrophils, interleukin 8, and also L-type fatty acid binding protein. So they all are used for our kidney injuries. Okay. So we'll take a break, then we'll do the remaining part. Just give me, so we'll take 10 minutes break. We'll start at 12:05. So 10 minutes break. So 10 minutes break. I'll come and then we'll continue. Okay. Take a break. So let's start. I am back. Break over. Let's continue. Join in, please. Please join in. We have started. Please join in. Okay. So let's continue. Okay. Hepatorenal syndrome is basically a failure of the kidney due to liver disease like cirrhosis. So that is called as hepatorenal syndrome. Finding there will be decreased GFR, decrease in output, increased creatinine, but there is no morphological defect in the kidney. That is called as the hepatorenal syndrome. Okay. Chronic kidney disease are called when the duration is more than 3 months. So if it is more than 3 months, it is called as your chronic kidney disease. Okay. What are the finding here? Two. One is decreased GFR less than 90, and there is albumin urea. That is protein urea which is there. Okay. Now what are the grades of GFR? The grades are 5 grades. What are the 5 grades? First is if it is more than 90 ml, it is normal, grade 1. Okay. If it is less than 90, that is 89 or below, is called as your grade 2. Less than 60, so you can remember it, my easy method. This is, I think, less than 80, less than 90, less than 60, less than 30, less than 15. Easy. So less than 90 is grade 2, less than 60 is grade 3, less than 30 is grade 4, and less than 15 is grade number 5. Are you clear? Now albumin urea. So that's why if it is 30 milligram per gram, it is grade 1. If it is 30 to 300, it is grade 2. More than 300 is your yes. This one. Okay. Fine. So clear now? Okay. So mild is 30, less 30, 300 is moderate, more than 3 is severe. Now, what are the causes? Most common cause of chronic kidney disease is your diabetes, and it show Kimmelston, Wilson, nodular glomulosclerosis. What are the hallmark? It is Kimmelston, Wilson, nodular glomulosclerosis. Initially, there is the increased GFR, polyuria. Later, there is decreased GFR and with protein urea. Now comes the question. Second is hypertension. Hypertension causes malignant nephrosclerosis, which is flea-beaten kidney. You see red dots, that is the case. So you can have the hemorrhages on the surface, that is called as flea-beaten kidney. So which kidney? Flea-beaten kidney. Okay, flea-beaten kidney. Okay, flea. So flea-beaten kidney. Okay, right. So this is the flea-beaten kidney. Then glomerulonephritis, chronic UTI, obstruction, PCKD, polycystic kidney, they all cause chronic kidney failure. Management is almost similar. First is control BP. Drug of choice I told you already is ACE inhibitor. Then correct the blood sugar. Okay, correct hyperkalemia and acidosis. Again, you can use dialysis. Protein and salt restriction, fluid restriction. Also fluid restriction. Okay. Then allopurinol for gout. Okay, fine. Then erythropoietin can be given. Spelling is wrong. erythropoietin, okay. So erythropoietin, okay, and also calcium and phosphate, vitamin D for osteoporosis, dialysis, renal transplant. So when do you go for renal transplant? If creatinine become more than 10 or burn become more than 36, then we can go for our which condition? Then we can go for our renal transplant, okay. Now, tubular disorders. Here, the tubules are damaged. The first is Liddle syndrome. Name is Liddle, but it's autosomal dominant. So, Liddle is what? It is autosomal dominant. Mutation is in beta and gamma subunits of ENaC. So, what is the mutation in? It is in beta and gamma subunits of ENaC. Okay. It prevent breakdown of ENaC. That's why there's an increase in ENaC activity. And I told you in physio, ENaC cause more sodium reabsorption. So that's why it resemble cones. So what are the two same conditions? Liddle and cone. But in cone, aldosterone is more. But in Liddle, the aldosterone is normal. That's why it's also called pseudo hyperaldosteronism or pseudocones. So who's pseudocone? Liddle is pseudocones. Okay. Drug of choice is amyloride. Okay. Then there's Bartter syndrome. Bartter syndrome resemble which drug? Loop diuretics, which I told you in pharma also. There's a Barton gene defect. So decrease activity of loop of Henle NKCC, which is sodium potassium chloride co-transporter. In which area? In the thick ascending loop. So in which area? In the thick ascending loop. For the hallmark, there's a loss of what? Sodium, water, and what? All solutes in urine. So what solutes? All solutes are lost in the, for the blood picture, hypokalemia, hyponatremia, hypophosphatemia, hypomagnesemia, everything is lost. Everything is lost. ठीक है, सही है. क्या चीज शाबाश, मैं मिस कर गया मेरे भाई, मैं देखा नहीं क्या बोल रहा था. ठीक है. Okay. So ascending loop of Henle contain what? It contain our, yes, NKCC. If NKCC is damaged, it causes Bartter syndrome, which is the same transporter blocked by loop diuretics. Are you clear? Yes. Next question. There is also, yes, increase PGE2, prostaglandin E2, and there is metabolic alkalosis. Okay. Age of presentation is early life because of genetic disorder, so it's early life. And there's polyuria, polydipsia, hypokalemia, plus, yes, sensory neural hearing loss because of loss of potassium. Drug of choice is not there, some specific drug. We basically give solute replacement and prostaglandin E2 blocker, indomethacin, okay, plus ACE and ARB, renal transplant is the final. Gentleman syndrome look like thiazide. What they block? Autosomal recessive. Defect is NCC. What is NCC? Sodium chloride co-transport in the early DCT. So that's why they are very similar to what drugs? The thiazide. Loss of all ions occurs. So what is loss? All ions are lost, okay, except the calcium. So calcium is not lost. So what is not lost? Calcium is not lost. All other ions and substances are lost, okay. What the difference with Bartter? The difference with Bartter is normal prostaglandin. This normal plus calcium can be normal or high. Where all are lost? See, summary. Liddle, sodium high, potassium low. Bartter, all low. Bartter, all low. Here, all low, but calcium is high. So here, calcium high, other low. So that is the summary of what? Our Bartter and Gentleman syndrome. So Bartter syndrome and the Gentleman syndrome. Bartter and Gentleman. Okay. Next question. Now we'll discuss glomerular diseases. It's a defect in the glomerular filtration membrane. Hallmark is proteinuria. So what is the hallmark? Proteinuria. There are two main types. One is nephrotic syndrome and nephritic. So remember nephritic, free, French fries. So when you eat French fries, what do you eat with? Coca-Cola. So Coca-Cola urine. So if you get a Coca-Cola urine, that is reddish brown urine, it is your hematuria. So what is hematuria? RBC in the urine. So RBC cast are there. So if you get proteinuria with hematuria, Coca-Cola, it is nephritic. If only proteins come, that is called as nephrotic syndrome. Okay. So what is not seen? Yes, no hematuria. Okay. Also hypertension can be seen in nephritic. So remember, hypertension, hematuria, is nephritic. So hypertension and this is hematuria. So hematuria, hypertension, Coca-Cola. Okay, so that are the findings. Okay. Then there is also proteinuria, very high in case of nephrotic, more than 3.5. Here it is subnephrotic. So which value? It is subnephrotic, less than 3.5. So which one is less than 3.5? It is our subnephrotic. Then there is also selective proteinuria. Mainly what? Albumin urea is there. So what is there? Mainly albumin urea is there. So mainly what urea? Albumin urea. Okay. Done. Then there is also lipid urea. There is also lipid urea in the case of nephrotic syndrome. Loss of protein, CNS, they all are absent in nephritic. Okay. Then also decrease immunity, increase infection. So means more findings of immunity, protein loss, lipid urea, all are seen in case of nephrotic. There is also more edema. Okay. Especially facial edema, periorbital. Treatment is same of both. Here we give steroids and immunosuppressants. Okay, dietary supplements. Okay, here we give again same steroids and immunosuppressants, and also we give ACE inhibitor. So remember summary: if only proteinuria, proteinuria. Okay, proteinuria with hematuria, if it is with hematuria, what does it become? It become our nephritic syndrome. And if without hematuria, that's Coca-Cola urine. If no hematuria, nephritic. Now nephrotic. Also lipiduria. Also there is lipid urea. So lipid urea is also there, plus protein loss, infections, and more edema. Treatment, treatment again. Here we give steroids. If not working, immunosuppressants. Here ACI and steroids. So ACI and steroids. ACI and steroids. Clear? Done? Now see the causes. Nephrotic syndrome, overall most common is diabetic nephropathy. Children, it is minimal change disease. Adult is the brother of minimal change, called as FSGS. FSGS. Okay. FSGS. Very good. Okay. Now, minimal chain disease is mainly idiopathic but can be autoimmune infection or there is a damage to podocyte which causes proteinuria. This causes a proteinuria. On microscopy, there is no finding. That's why it's called as minimal change disease. But when you do electron microscope, you can see damage to podocytes. So that is your electron microscopic finding. Damage to the podocyte. Mostly children is there. Young child presents with edema, periorbital swelling. Okay. With there is decreased plasma albumin, muscle wasting because of protein loss, poor growth, increased infection, dyslipidemia, etc. So what is the investigation? Urine proteins are increased, mainly albumin. Very good prognosis. When you give the steroid, respond very well. What is the respond with steroids? Mainly prednisolone. Prednisolone. How much? 1 milligram per kg per day. So 1 to 2 is the book value. So 1 to 2. So if not working, we can increase the dose to 2. If steroid resistance, they are not working. If there is steroid resistance, then we can go for immunosuppression like cyclophosphamide, azathioprine, tacrolimus or cyclosporin. So they can be used in case we can't use the steroids. Okay. Also, there's now a new drug that is monoclonal antibody Ritu. So rituzumab. So Ritu क्या करती है? Yes, immunity को रोक देती है. So Ritu ने immunity रोक दी. सही है? Ritu. And also we can use statins for dyslipidemia protein supplements. Okay. Adults have FSGS, which is very similar to the minimal chain disease, focal segmental glomulosclerosis. Treatment is same, steroids and immunosuppressants. These are finding, no one asked you. Nephritic, most common cause in children is PSGN, post streptococcal glomerulonephritis. First, there is a streptococcal infection, there is pharyngitis or maybe impetigo with strep pneumoniae or pyogenes or viridans. Then after 4 to 6 weeks, there is Coca-Cola urine, RBC cast, edema is less, but there edema is less. Then there is proteinuria less than 3.5, and there is a decrease in complement protein because they are used to make the complex. So it's a type 3 hypersensitivity, immune complex deposit and damage our glomerulus. Yes, complement level decrease. So that's the main hallmark, decrease in complement level, decrease. Yes, puffy face, very good. Yes, Prashana, is true. And again, treatment is same. We check ASO titer, which is anti-streptolysine. Also check in what? Rheumatic fever. So also increase in rheumatic fever. Treatment is same, but we give ACI, okay, plus steroids, immunosuppressant, rituximab, antibiotics can be used, okay. Berger disease is also called as IgA nephropathy. Most common cause of nephritic syndrome in adult is our Berger disease. So what is Berger disease? It is our, yes, most common cause of nephritic syndrome in the adult, okay, is called as what? Nephritic syndrome. It is called as the nephritic syndrome. Fine. Next question. It is similar to PSGN. Okay. There is the upper respiratory infection. Then there is hematuria, proteinuria, hypertension. Main finding is biopsy. We do immunofluorescence. You will see this green shining neon light like your marker like green color. And this green color deposit are basically the IgA deposit. Okay. Plus crescents can be seen in the, yes, electron microscope. These are the cellular crescents, moon shape. So called as crescents. Okay. So crescents, immunofluorescence, they are finding of IgA. Yes. Treatment is again same, ACE inhibitor, ARB, steroid, immunosuppressants. Good-Pasteur syndrome is anti-GBM antibody. What is GBM? Glomerular basement membrane antibody. So they could be in the lung also because there is basement membrane there also, or kidney also. So both are damaged. G for glomerulus and P for pulmonary. So damage to glomerulus membrane and the pulmonary basement membrane is called the Good-Pasteur syndrome. Good-Pasteur syndrome. Okay. Okay. Now, if there is a destruction of glomerulus, again there is a hematuria, okay, plus also hemoptysis. So double feature, that is hematuria plus hemoptysis are feature of what? They are features of our which condition? Yes, answer, it is features of our, yes, Good-Pasteur. Okay. Now it can cause RPGN. What is RPGN? Rapidly progressive glomerulonephritis, which causes renal failure. Okay. Treatment is same as nephritic syndrome. Now nephritic syndrome other causes are SLE, then Henoch-Schönlein purpura, then this PAN, polyarteritis nodosa. It should be PAN, not this PAN. Then ANCA vasculitis, etc. They all can cause nephritic syndrome. Okay. Now we'll discuss liver. Liver basically is for metabolism. So it basically make lipid, protein, glycogen, fat, also albumin, globulin, clotting factor, and also store vitamin A in the ITOR stellate cell. And it break the drugs, toxin, alcohol, also convert ammonia to urea, which is water soluble and remove in the urine. So who convert ammonia to urea and remove in urine? Answer is liver. Okay. So that's why liver disease ammonia increases. This ammonia can go to brain, damage the brain, and that is called as what? Encephalopathy. Clear? So encephalopathy. Okay. Chal. RBC breakdown, hemolysis occur in spleen. Littoral cells are there, the macrophages of this. So who's the macrophage of the spleen? So they are the main and macrophages. So spleen macrophages. And who are the macrophages of the liver? It's Kupffer cell. So Kupffer cells, it should be double Kupffer, double F. Again spelling mistake. Kupffer cell. Okay. Lifespan of RBC is 120 days. Now RBC breakdown will release heme. Heme is converted to biliverdin, bilirubin. Bilirubin initially is unconjugated, lipid soluble, so it cannot come in urine. It need to be converted to water soluble. This I discussed in pediatrics also, to what? Conjugated bilirubin, and now it can come in urine also if by chance it comes to urine. Now liver convert unconjugated bilirubin into conjugated bilirubin by which enzyme? UDP glucuronide transferase. So UDP glucuronide transferase. Now understand, if there is too much hemolysis, there will be increased unconjugated bilirubin that cause yellow skin, yellow eyes, but urine is normal because it cannot come to urine. This is called as pre-hepatic jaundice. What is it called as? Pre-hepatic jaundice. Increase bilirubin more than 2 mg/. If newborn, we take 5. So in adult, 2, newborn 5. Then this conjugated bilirubin bile is secreted into intestine by the bile duct, and now the bacteria convert it to stercobilin, which come in feces. But if there is an obstruction, this bile cannot come to intestine, so that will be intestinal obstruction, but the bile will regurgitate into the blood. So in the blood, what will increase? Conjugated. So that's why there is an increase conjugated. It is post-hepatic. Is which one? Post-hepatic. Okay, post-hepatic or obstructive jaundice. So post-hepatic or obstructive is what? Conjugated bilirubin is coming, and it can come in urine. That's why it causes dark yellow urine. So remember the story. If there is increased hemolysis, it causes increased unconjugated bilirubin, also called as pre-hepatic jaundice. If there is an obstruction of bile duct, what increases? Conjugated bilirubin cannot go to intestine, so it will come in the blood, and if it come in blood, there is a conjugated bilirubin in the blood. This is post-hepatic or obstructive jaundice. Are you clear? Done? Okay. Naveen, light criteria I have already explained in pulmonary lecture. Okay, clear? Just check the protein in LDH. Okay, protein in LDH. Next question. Hepatic jaundice is basically inflammation of liver, and it shows features of both. So what does hepatic show? Features of both. So that's why in hepatic there is an increase in both unconjugated and conjugated. So if there is the obstruction, it is post-hepatic. If hemolysis, pre-hepatic. If liver disease, both, like hepatitis, cirrhosis, it show both. So what causes here show both conjugated, unconjugated, pre-hepatic, post-hepatic? It is hepatic disorder. Now main thing, what is happening? Just remember, fat absorption is poor in both hepatic and post-hepatic. Why? Because the bile is not going to the intestine, so fat is not absorbed, so fecal fat increase. It is clay white foul, मतलब बिल्कुल घी जैसी टट्टी. कैसी? white घी जैसी. घी, it look like what? Like ghee, butter. So ghee, butter. So very bad feces, foul smelling ऐसे, and also very greasy, चिपक जाती, flushy नहीं होती. ठीक है? So where do you see increased fecal fat? It is hepatic and post-hepatic. Hepatic and post-hepatic. Okay. What is it called? Steatorrhea. So what is poor fat absorption seen in? In hepatic and post-hepatic. Liver enzyme are increased mainly in liver diseases. So that's why liver disease may be post-hepatic, but mainly liver disease they increase. And alcoholic is GGT, gamma glutamyl transferase. So gamma GGT, glutamyl transferase is mainly increased in which case? In alcoholics. Then alkaline phosphatase indicate obstruction, increase mainly in obstructive condition. Splenomegaly because of breakdown of RBC occur mainly in pre-hepatic, and urine urobilin increases again in the pre-hepatic. Okay. Now if there is a jaundice with yellow sclera, ask for urine color. If urine color is normal, it's unconjugated, might be pre-hepatic. We'll check for hemoglobin, RBC, splenomegaly, pre-hepatic. We'll do what test? We'll check the blood analysis, we'll do bone marrow analysis, all this. If urine is dark yellow, it's conjugated, could be hepatic or post-hepatic. If liver enzyme increase like ALT, AST, is AST? AST, let me just make it. AST, okay, is hepatic jaundice. And if there is a fever, pain, might be hepatitis. So if there is a fever, suspect hepatitis. Fever, pain, hepatitis. If not, maybe bile stones. Okay, so that is your post hepatic. So the increased alkaline phosphatase, will do ultrasound, will do ERCP, MRCP, and also HIDA scan. HIDA scan. So what will do? HIDA scan. So HIDA scan is the gold. शाबाश, बस याद कर ले मेरे भाई, ये चार्ट याद कर ले. अगर अनकॉन्जुगेटेड बड़ा हुआ है, देखो भाई कुछ मत याद करो, बस याद कर ले. अगर अनकॉन्जुगेटेड ज्यादा है तो ये प्री हेपेटिक है. ठीक है मेरे भाई, पक्का हीमोलिसिस हो रही होगी. तो क्या चेक करेंगे? ये बन गया आपका टेस्ट. क्या चेक करेंगे इसमें? पेरिफेरल स्मेयर, बोन मैरो एग्जामिनेशन लाइक एस्पिरेशन, बायोप्सी. जस्ट रिमेंबर प्री. अगर कॉन्जुगेटेड है तो या तो हेपेटिक होगी और पोस्ट हेपेटिक ऑब्स्ट्रक्टिव. पोस्ट हेपेटिक ऑब्स्ट्रक्टिव. पोस्ट hepatic obstructive. So post hepatic obstructive. Are you clear? Hepatic में what happens? Increase liver enzyme. AST, ALT. Here there is increase alkaline phosphatase. So increase alkaline phosphatase. So what increases? Alkaline phosphatase will increase. Are you clear? And also in this case there is also, we'll do ultrasound, ERCP, MRCP, HIDA scan. What the idea? बस ये याद कर ले मेरे भाई, और कुछ मत याद कर. ठीक है, हिडा ये स्टोन्स है, पक्का स्टोन्स है, 9-10% स्टोन. और ये क्या है? अगर फीवर पेन है तो ये, अगर कुछ भी नहीं है तो हो सकता है सिरोसिस हो, अगर पेन वेन है तो हो सकता है ये स्टोन हो. So, ये क्या हो सकता है आपका? इफ फीवर पेन हेपेटाइटिस. एल्स सिरोसिस. आप सही है, खत्म. तो अगर फीवर पेन वाला लग रहा है तो हो सकता है कि ये हेपेटाइटिस हो, अगर नहीं है तो फिर ये सिरोसिस हो सकता है. इजी. ठीक है, चलो. सो आर यू ऑल क्लियर विद दिस? यस. Just remember this summary, everything will be solved. Let me now discuss the viral hepatitis, very important. Hepatitis A is the most common cause of hepatitis, is orophycal. Remember A and E, A to E is your, yes, orophycal, okay, and is mostly asymptomatic but can cause our fulminant, can cause fulminant. So mostly asymptomatic but can cause fulminant. Rare but can cause. All Indians are immune to hepatitis A because we are all exposed. Golgappa, chaat, tikki, whatever you eat, you're always getting, yes, hepatitis. क्यों? The Golgappa person fecal root and he make the food, this dirty hand containing the hepatitis virus, you eat all this and you get orophycal infection. Don't feel disgusted, you already have it. Already हो चुका आपका. Then hepatitis E is pregnancy. Hepatitis E is pregnancy. Again orophycal, mainly cause fulminant in pregnancy. B, C, D is blood and sex. So that is blood transfusion, IV drug user, just like HIV, AIDS. So what are BCD? They are same as HIV, either by unprotected sex, not just sex, unprotected. भाई सच कड़वा लगता है पर यही है, unprotected sex with person with hepatitis. Okay, never ever look in the kitchen. If you look in the kitchen, you might not feel like eating food there. Even 5-star hotels, restaurant, see, food can never be clean, understand? Okay, if you're eating meat, do you think this meat is clean? Never. The meat will never be clean. It will have parasite, it'll have all kind of infection. Maybe if you're eating veg also, again, do you think bacteria, viruses, all this pathogen, insects not there? They are there. Then if you eat wheat, wheat will always contain rat excreta. I don't want to disgust you, but accept the fact. Okay, खाना साफ नहीं हो सकता, गंदा होता, खा लो, ठीक है, खा लो, ठीक है, बस जिंदा रहना है तो खा लो. Let's move on. Okay. Okay. Hepatitis B, HIV. We use mainly 3 main drugs, that is tail drugs. What is tail? Tenofovir, entecavir, lamivudine. Okay. So the 3 main drugs we are using in hepatitis B, chronic one, chronic. So chronic hepatitis B and HIV, the 3 drugs we use is tail. तेल लगाओ. तो क्या बोलना है? हेपेटाइटिस और एचआईवी को तेल लगाओ, तेल लगा के इलाज कराओ, तेल लगाओ, तेल. तो क्या है तेल? यस, वो है टिनोफोविर, एंटेकावीर, लैमीवुडिन. तो कौन से तेल है? तेल लगा ले, तेल. सही है. चलो, हेपेटाइटिस सी मोस्टली कॉजेस chronic hepatitis, mostly causes chronic hepatitis. Okay. Hepatitis D is dual, so it causes a co-infection, dual infection with hepatitis B and cause the fulminant hepatitis. Now we'll discuss the hepatitis B. It is also a DNA virus. It's a DNA virus called as Dense particle. What is it called as? Dense particle. It is basically 3 main virus antigen. One is the surface antigen, surface HBS, called as HBS AG. HBS AG. Then it has a envelope HBE antigen envelope, and then it is a core antigen is there. Okay, so core, this is a core. So core, envelope, this envelope, and this is the surface. Now mnemonic is sex. Mnemonic is sex. What is sex? Is SECES, sex. So what is the mnemonic of this? Sex, not wala sex. Sex. So remember sex. Yes. तेल से हेपेटाइटिस को पेल दो, तेल लगाओ और हेपेटाइटिस को पेल दो. बिल्कुल सही क्या. सो एस और ई एंटीजन है, CEES एंटीबॉडीज है. सही है. तो एस और ई क्या है? एंटीजन. एंड व्हाट इज CES? एंटीबॉडी. एस इज योर हेपेटाइटिस बी एस एंटीजन. It means infection is present. Are you clear? So what indicate infection is there? It is hepatitis, and this is your antibody against S. So it's anti HBS antibody. अगर ये आ गई मतलब infection is over. Infection is not there, infection is over, and immunity is there. Easy. So remember, if there is antigen, infection is there. If antibody, no infection, immunity is there. Are you clear? Now E. E is our envelope. HBE antigen. It means replication and infectivity, that is acute infection. Acute infection. Okay, fine. If C come, C is core, so it's anti HBC antibody. So it's core anti. Now it is 2 types, either IgM or IgG. If M come, it is acute infection again. if G come, it is your chronic infection. So G would be chronic infection. So G is your chronic infection. So what is chronic infection? G is our chronic infection. So what is chronic infection? G is the chronic infection. Okay, fine. Now if immunity is there, just check. If there is, yes, anti-HBC present, that means there was past infection which caused the immunity. Past, not current, past infection. But if antibody against HBC is absent, that means there is no infection, vaccine. That is, there is vaccinated. This is 100% exam question. Never ever ignore it. This table will be there in the exam, and if you have done the class, understood, you will surely pass the exam. Are you clear? Clear? So clear? Okay, let's continue. So this I've discussed already. So antibody, all. So if infection, what is the marker? For infection, it is HBs antigen. Acute is IgM. If chronic, IgG. This is the spectrum of this. Once antibody against S come, infection is over. So that is why. And what persists all life? Anti-HBC persists if there is a past infection. Okay, along with anti-HBs. If they both are there, it is recovery and immunity. Recovery and immunity. Recovery and immunity. So conditions: if there is HBs antigen present, acute infection is there. Acute infection. If anti-HBC and these are absent, that is only acute infection. If acute infection, IgGM antibody is there, HBC, but not having the surface antibody. Okay. If chronic, again it will be IgG. Okay, but absent. But if recovery, past infection, so if recovery and past infection, there would be, yes, this is absent. This absent means the person is no longer infected. He is either cured or vaccinated. IgG anti-HBC means it is past infection, and if they are absent, it is vaccinated. This table I've discussed. Treatment for acute hepatitis B. Treatment is interferon. So what do we use here? Interferons are to be used. So what do we use here? Interferon. So interferons are to be used. So what is used? Interferon. Okay. Alpha. And chronic tail. Is tail. Okay. Acute liver failure. First is mostly toxins, but could be hepatitis. In B and E, in pregnancy is E, also cirrhosis. If less than 8 weeks, it's called as fulminant. So if there's a failure within 8 weeks, it's called as fulminant liver failure. Most common cause is hepatitis D. So if they say fulminant liver failure, answer is hepatitis D. Finding will obviously, if liver is damaged, you can't make clotting factor. So your INR increase. Why? Because of clotting factor defects. Okay. And PT also increase. So remember, INR and PT increase because of what? Clotting factor deficiency. Okay. Sultana, this graph I told you, just remember, is like this. What is first to come? HBS. What come? HBS. And it will decrease once the recovery starts. So this is a window period, recovery start. So the gap between end of HBS and start of anti-HBS is called as a window period. Why window? Because here you don't have the anti-S, so that means you're not sure immunity is there or not. And the antigen is also not seen much. So that is why it is called as window. In window, we'll use the HBC antibody. What antibody? HBC antibody. INR is international normalized ratio. INR is, yes, internationalized normalized ratio, international normalized ratio. Okay, it's a ratio of PT, is a ratio of PT. Okay, done. Okay, Sultana. Yeah. Then hepatic encephalopathies increase ammonia. So as there is liver failure to convert the urea, what happens? The ammonia is now crossing the barrier, damage the neuron, and the features are changes in personality, confusion, ataxia, amnesia, apraxia, which tremor? Flapping tremor called as asterixis, dysarthria, increased deep tendon, all upper motor neuron lesion. They are very similar to upper, and there is asterixis, this flapping tremor called as asterixis, flapping tremor. Okay, and there is coma, hepatic coma. EEG will show abnormal triphasic wave. So which waves are there? Abnormal triphasic wave. Other findings of liver failure are jaundice, ascites, edema, then nausea, vomiting, caput medusa, spider angioma, which I'll show later. Investigation is we check the bilirubin, albumin, INR, PT, liver enzyme, alkaline phosphatase, ammonia, etc. They all will be the finding. Albumin will decrease because the liver is not making. Clotting factor decrease, but INR, PT increase. Treatment लोला, क्या देना इसको? लोला. क्या दोगे इसको? तेरा हो गया लिवर खराब, तेरे को हो गया क्या? एंसेफेलोपैथी, ले लोला. लोला क्या है? L-ornithine, L-arginine. L-ornithine, L-arginine. Then drug of choice for hepatic encephalopathy is N-G-lactulose. It's a laxative. It causes the flushing of GIT and ammonia is lost. तो क्या करना है इसको? लैक्टुलोज. तो क्या देना है इसको? लोला और लैक्टुलोज. तो लोला दो और लैक्टुलोज दो. ठीक है, फाइन. Yeah, tell me, Apritam, what do you want to ask? Then antibiotics, rifaximin or neomycin, they remove gut bacteria and clean the gut. Also, we need to give fresh frozen plasma to correct the clotting factor defect. Clear? Then IV dextrose to correct hypoglycemia. If liver is damaged, it cannot store and give the glucose. So that's why we need to correct the hypoglycemia. Okay. We'll finish this class around 5-10 minutes. Okay. Then I'll go for offline session. Then I have a flight. Okay. Clear? IV mannitol is given to reduce the cerebral edema. And final treatment is liver transplant. What is the final treatment? Liver transplant. We use the MELD cone, which is model for end-stage liver disease. So what stage? Liver disease. MELD score use bilirubin, INR, creatinine. Okay, this MELD score. Fine. So this is our MELD score. So now we'll discuss the cirrhosis, last topic. Then I'll finish. Clear? Baki hematology I'll discuss in separate session. Okay, after the class. Okay. So end stage liver disease is cirrhosis. It has two features. Fibrosis is there and also regeneration. So cirrhosis is like damage is also there, repair is also there. Most common cause is alcoholic liver diseases. So what disease? Alcoholic. So healthy liver, then NAFL. That is what? It is non-alcoholic fatty liver. So fat is deposited. Then there is non-alcoholic steatohepatosis. Okay, so what happened? It is now getting inflamed. Then there is cirrhosis. So cirrhosis what? There is a fibrosis plus there is regeneration also. Finally, cancer can also occur. What can also occur? Cancer can also occur. Then hepatitis can also cause the cirrhosis. Then non-alcoholic fatty liver disease or non-alcoholic steatosis. Okay, steatosis. Okay, metabolic disorder like Wilson disease, hemochromatosis or biliary cirrhosis, obstruction of bile duct, damage the liver, causes cirrhosis. Finding are obviously jaundice is there. Then there is ascites. Hands are red, called as Palmer erythema. Spider angioma. So this is red color dilated arteriole with spider like feet, called as spider angioma. Spider angioma. Then fat is deposited, called as xanthoma. Can you see this yellow color fat deposit? It's called as xanthoma. This is called as the xanthoma. Okay. Then clubbing can be there. Okay. Then dilated veins on the abdomen, called as caput medusa. It's called as caput medusa. Dilated veins on the abdomen. Then there could be bad smell coming from the mouth, just like a feces कि अभी shit खा के आया. So that is called as fetor hepaticus. Fetor hepaticus. Bleeding will occur. Why bleeding? Because of lack of clotting factor. edema is there because of excessive fluid accumulation. There is low albumin, which causes the gynecomastia can occur because of steroid, metabolism is defective. Nails show terry nail. This is red and white nail. So it is red and white nail called as terry nail. Then encephalopathy is there, which show flapping tremor, which I discussed. Could be gynecomastia, clubbing can be there. There could be deep uterine contractures, okay. Plus hepatomegaly can be there. Sometimes can be small also. And portal hypertension findings, which I'll discuss soon. And we'll see the, portal hypertension. And what is the classification we use for cirrhosis? ये exam में आया था, child pox. So what is the classification? Child pox classification, okay. See, xanthoma is just deposition, okay. It's deposition of fat in any body part. In body blood is called as, ठीक है, clear, Prashant? So xanthoma is just fat deposits, okay, clear? And pigmentation change is this asthma, okay. So when there's a change like melasma, so all the changes in color is called as this, okay, fine. Now what is the finding? It is increased bilirubin, decreased albumin, increased PT, ascites, and also hepatic encephalopathy. These are finding of child pox classification, okay. Now treatment is very similar to liver failure or hepatic encephalopathy. Lola देंगे, plasma देंगे, then we'll give glucose, all the finding. This I discuss. Last is portal hypertension. Most common complication of uncompensated cirrhosis is what? It is our portal hypertension. The portal vein pressure become more than 10. It can cause development of portal and systemic collateral. Portosystemic collateral, which is the case. So investigation of choice is Doppler. We'll do Doppler. Earliest finding is splenomegaly. What is the earliest finding? Spleno. But most liable sign of portal hypertension is ascites. Are you clear? And ascites is there, okay. In ascites we check SAG. What is SAG? Is serum ascites albumin gradient. So SAG is tested for diagnosis of ascites due to portal hypertension. Now, what is the dilated portosystemic collaterals cause? One, it causes esophageal varices, which can cause bleeding. So hematomasses occur, which can be very dangerous also. Then there is rectal hemorrhoids, again because of high pressure. There could be caput medusa, which I showed, dilated veins on the abdomen. Then the collateral can develop in the bare area of liver also, or also liver and omental veins. So which veins? Liver and omental veins. In varices, there is hematomasses. What is there? Hematomasses. The source of blood is coronary vein. So what is the source of blood is? It is coronary veins and can cause shock, or even death because of hematomasses. So treatment is octreotide. IV octreotide is the drug of choice. Not available, terlipressin can be used, but drug of choice is octreotide. Treatment of choice is endoscopy with bending sclerotherapy. So if they ask you what is the treatment of choice, we put endoscope and we will close the bleeding varices by bending. Put a band around it and squeeze, or sometimes we can inject a sclerosing agent and prevent the bleeding. And till then we can arrange the blood and we can give massive blood transfusion. So if varices present and bleeding, the drug of choice is octreotide. Treatment is endoscopy and bending. If non-bleeding, give propranolol. Sometimes we can also use what? Sangsticken Blackmore tube. It is put in the esophagus. Some part goes to stomach also, and we expand it, we inflate it, so it compress the varices and prevent the bleeding. So it is for compression and prevention of bleeding. So that is the case. Are you clear? So we can also use surgical intervention in case of this varices, called as what? TIPS. So what is TIPS is? TIPS is transjugular intrahepatic portosystemic shunt. So once again, what is trans is? TIPS is transjugular intrahepatic portosystemic shunt. So that is the case. Are you clear now? Okay. So are you clear is? Fine. Check. So I will finish it now. Okay. So we are finishing it. Okay. And yes, this is over. Now only left is the topic of what? Yes, we have covered that topic of hematology, which I will take later on. So I will take the hemato later on. So I'm ending the class, going for offline. Thank you very much. I'll discuss the questions very soon. Very soon we'll have a session in which I'll discuss the question. So test and discussion will occur very soon. So be ready for test and discussion. Chalo, best of luck. Take care. Medicine over finally. Acid base I'll do in discussion only. Okay, don't worry. Annam, I'll do acid base in the discussion. Okay, clear? Chalo, take care. Bye bye. We'll meet soon. Bye bye. Chalo, take care. Bye bye. Good night. So I'll just show you xanthoma also. Okay. So xanthoma is basically just deposition, and this pigmentation change is xanthalsma. So is the case. Clear? So can you see that? So fine. Fine. So it is just a xanthoma which is causing a pigment change in the eyelid. Clear? So they are almost same condition. Okay. So then xanthalsma is pigment change and xanthoma is the deposition of cholesterol fat. Are you clear now? Fine. Chalo, take care. Good night. Bye bye.